Our next speaker is Emily Perrin, and she is an assistant professor from the VCU School of Pharmacy. She earned her degree from Butler University and her MS in clinical research from the University of Pittsburgh. She's completed a residency and fellowship training and specializes in geriatric pharmacy practice and research. We're happy to have her here today and hope you will enjoy her talk. She'll be here till 11:10. Thank you. Yeah. Please welcome Emily.
Hi guys. Can everybody hear me? Great. Thank you so much for coming back for me. I know it's always hard to be the speaker right after a break and also kind of in that in-between breakfast and lunchtime. So I'm going to talk today about medication use in Parkinson's disease from a pharmacist perspective. So we're going to talk about three big topics today. First and foremost, we're going to talk about medications used to manage the motor symptoms of Parkinson's. So those are the movement problems associated with Parkinson's disease. I'm also going to talk about prescription medications to be avoided or used with caution in Parkinson's disease. This is a big topic that I run into, especially in hospitalized patients, when maybe there's some unclear data about what we can or can't use. Also, I'm going to talk a little bit about navigating the over-the-counter section of the pharmacy. I'm just getting over a cold myself and have navigated that in the last couple weeks, and it is a frightening place to be. So I'll try to give you guys some tips and tricks to use when you're trying to find cough and cold medicines and also stuff for constipation. So before I begin, I just wanted to clarify a couple of terms. I know we had a great introduction at the beginning of this day to Parkinson's disease and the symptoms and a little bit about management. But I think it's important for those of you who are new to the Parkinson's community to understand what I'm talking about when I say motor symptoms. And specifically what I'm talking about are the things that we can see in a person with Parkinson's. So things like tremor, so that's shaking, bradykinesia or slowness of movement, rigidity, which is the stiffness of movement, so the inability to kind of make big sweeping motions, right? It's a little bit stiffer. And last but not least, postural instability. And so this is really one of those that's a little bit harder to define, but really just relates to the fact that patients with Parkinson's are more likely to fall because of some imbalances that they feel. When we're talking about medications specifically used to treat motor symptoms of Parkinson's disease, the three symptoms that are bolded here, the tremor, the bradykinesia, and the rigidity, are the ones that are really going to be targeted by medications. That last one, that postural instability, that tendency to fall, is going to be a lot harder to target. So really when we're talking about medications used to treat motor symptoms, we're talking about medications used to treat those first three. A couple of other things I would be remiss if I didn't mention. Dopamine and acetylcholine, these are going to be the big words for the day. So dopamine is, they're both chemicals that we see in the brain, both dopamine and acetylcholine. Dopamine is the one that we associate most commonly with Parkinson's disease, though, right? Because Parkinson's disease is associated with what, an increase or a decrease in dopamine? Decrease, right. So we're trying to replenish the dopamine storage in the brain so that our movements can get back to normal, or as close to normal as they can. Now, acetylcholine we're not going to talk as much about, but it will come up in some of the drugs and how they work. So just keep in mind that these are both chemical messengers in the brain that are used to manage motor function. So there's a couple of different ways in which Parkinson's medications can work. And there's a lot of science behind this and a lot of, as I mentioned, big words, lots of dopamine and acetylcholine flowing around. But I'm going to try to break this down so that it makes sense to how these medications are working in your body and how they're helping you or your loved one manage their symptoms. So the big way that we use, and the most obvious way that we use medications, is to increase dopamine, right? We talked about Parkinson's being a disease of decreased dopamine. The natural tendency is to want to increase dopamine. So the big drug that we use for that is carbidopa and levodopa. And then we've got a couple of other helpers that we'll talk about. So carbidopa, levodopa, or Sinemet is the mainstay of therapy, right? If you haven't been on it, you've probably heard of it and will probably be on it at some point, right? So levodopa is actually the main ingredient in carbidopa, levodopa that gives us that bump in dopamine. And it's because levodopa is actually converted into dopamine in the brain, so it replaces what's lost in Parkinson's disease. It's a pretty logical thing to do, right? You're taking those stores from empty to full with dopamine. So this product comes in a couple of different varieties. We've got Cinemet, we have Cinemet controlled release, so it'll act a little bit longer. And there's also an orally disintegrating tablet, so you can put it on your tongue, it dissolves, you don't need water. And so depending on your disease, your symptoms, how often they occur, your neurologist may put you on one or a variety of these. So you may use Cinemet immediate release at some point in the day and Cinemet controlled release at another point in the day. Just depends. So I'm not going to make any specific recommendations about what you should or should not be taking, but I do want you to understand why you're taking these medications and how they can help. So I mentioned that levodopa is really the big one, right? That's the part of this drug that is converted to dopamine. It does the job of dopamine. But carbidopa is a little bit harder to understand. It's just kind of this add-on thing that's part of a combination product. But what carbidopa actually does is it allows more levodopa to get to the brain. And it also helps to decrease nausea that's associated with the use of levodopa. So I consider carbidopa to be almost like a bodyguard, right? It helps the levodopa get into the brain where it needs to act so that you don't lose that dopamine other places in the body before it gets to where it needs to be. Does that make sense? Okay. So there are a couple of unique side effects with Cinemet or carbidopa-levodopa that we have to mention. We're going to talk a little bit about the general side effects later, but specific to carbidopa-levodopa, we see a couple of motor fluctuations, which many of you are probably familiar with. One of those is wearing off. So this is where the medication, you take a dose, it has its intended effect, works in 20 to 30 minutes, works for a couple of hours, but then before you're due to take your next dose, before that next dose is usually due, something happens, right? The medication just stops working the way it's supposed to. And so this is really wearing off. And this is something that will happen over time. It may happen in a few months. It may happen in a few years. It really depends on the person. But this is something that's very common with carbidopa-levodopa and something that oftentimes will lead us to increase the frequency with which we're taking the medication. There's another thing that we see with carbidopa-levodopa that's a bit unique, and this is what we call dyskinesias. Okay, so this is kind of like that rhythmic or dancing movement that we can see with Parkinson's disease. And so it's not the Parkinson's symptoms, although oftentimes people think it is, but it's actually a side effect of the medication. And it most commonly occurs sometime in the 30 minutes to 2 hours after you take your dose when the concentration of dopamine is the highest in your body. And it's basically just causing either, again, these dancing movements, or it can also cause some stiffness, some contraction, so where you're kind of stuck in an awkward position. And so these are just two examples of dyskinesias that we may see with carbidopa-levodopa. And in some cases, they're problematic, but in other cases, patients will say that they'd rather have the dyskinesias than have the symptoms of Parkinson's, right? So those of you who have taken this medication can probably relate to this. So carbidopa-levodopa, really, you have a nice honeymoon period for a few years before these dyskinesias start to kick in, right? But after about 5 to 7 years, we see about 50 to 70% of patients experiencing dyskinesias. So this is unfortunately a very realistic part of taking this drug. Even though it's the best that we've got for Parkinson's disease symptoms, for those motor symptoms, it does come with side effects, and we need to be aware of them. So you may use this initially for therapy. This may be the first drug that you're put on, or it may be something that 10 years down the road into the course of your disease, your doctor decides it's time for this. It just depends. So there's another class of medications that I want to talk about, and this is kind of the other bodyguard for levodopa, right? So this is again going to allow a larger amount of levodopa to reach the brain. It works in a very similar way to carbidopa in the sense that, again, it's helping levodopa get to where it needs to be to make its effect. It's also used with levodopa to make the drug last longer. So if you're having that wearing off, sometimes one of the things that we can do is add what's called a COMT inhibitor. COMT stands for catechol O-methyltransferase. If there's any scientists in the room, I'm sure you'll be interested to know that. But this comes in a couple of different formulations. We've got some plain tablets that come with the COMT inhibitors in them. So entacapone and tolcapone, or Comtan and Tasmar, are the standalone COMT inhibitors. So you can just take one of those when you take your Cinemet, and you'll get the benefit of the drug. But there's also a combination product that some of you may take, which is called Stalevo. And so this is a combination pill that includes the carbidopa, the levodopa, and the entacapone into one easy-to-take tablet. So the issue with this is that there are, again, some unique side effects. not only because you're making the levodopa last longer and you're intensifying its effect, do you have the potential to have more significant levodopa side effects, but also there can be some reddish colored or rust colored urine. It's usually benign, but definitely something that you'd want to mention to your doctor. And delayed onset diarrhea, kind of a random one, right? But about 6 to 8 weeks into using, maybe give or take a couple weeks, you can start to experience some diarrhea. If it's severe and problematic, again, something to report to your doctor. The other thing that we oftentimes see and hear about in the news, and if you're reading updates on any of the Parkinson's websites, you probably heard when tolcapone, they had some changes with the liver monitoring of the drug, but there can be some side effects that affect your liver with that drug in particular, and so oftentimes we'll use entacapone or Comtan before we use the Tasmar. But it's not to say it's a bad drug, it's just that you want to have your liver checked out more regularly if you're taking the tolcapone. All right, so MAO-B inhibitors, again, there's the scientific word, monoamine oxidase-B. MAO-B inhibitors, again, all of these drugs are really serving to protect levodopa in this case. And so MAO-B inhibitors, what these actually do is they work a little bit differently, but they still act as bodyguards for dopamine. So dopamine is actually churned up and taken out of the body, and it's churned up by monoamine oxidase-B, okay? And so if you inhibit that enzyme that churns up the dopamine, you allow dopamine to stay in the brain longer and have its effect for longer. So a little bit different than the COMT inhibitors, but with the same goal in mind, to help that levodopa and help that dopamine stay in the brain, work as long as possible, and give you the most bang for your buck from your Parkinson's medicine. This comes in a variety of different forms. So we've got selegiline and rasagiline. Now these are drugs that I'm going to talk about a lot as we go through, because these drugs tend to have a lot of side effects, a lot of drug interactions, so definitely something to look out for. But we'll use these drugs sometimes before we even start levodopa carbidopa. It just depends, right? So because these drugs stop the breakdown of dopamine, they're not specific to being used with levodopa. You can just use them to keep dopamine in the brain longer. So we may use them alone, but then also we may use them in combination with that initial drug, the carbidopa levodopa. Just depends. You'll hear me say that a lot. It really does depend. And this comes in a couple of different formulations. Again, you've got tablets and capsules, but we've also got an orally disintegrating tablet that comes for selegiline, which is a really nice alternative, especially if you have difficulty swallowing. Couple of unique side effects to keep in mind. Same thing with those other drugs that are bodyguards for levodopa or for dopamine. These drugs will potentially intensify the side effects that you experience with levodopa. But also selegiline can be really nice for patients who experience a lot of fatigue and kind of tiredness. But on the flip side, as they're improving that problem, they can also lead to some insomnia, a little bit of agitation, and sometimes some vivid dreams. So that's something to look out for. And that is specific to selegiline. Rasagiline does not have that side effect. All right, so those are the drugs that increase dopamine. So we've got levodopa carbidopa, and we've got its bodyguards, which are the COMT inhibitors and the MAO-B inhibitors. Now we're going to talk about the drugs that mimic dopamine. Okay, so this is a little confusing to understand, but the basic idea of the dopamine agonists or the dopamine mimickers is that they fool the brain into thinking it's got more dopamine, although it's not actually adding dopamine to the brain. And so these are drugs that you're probably pretty familiar with. I know these are used oftentimes in restless leg syndrome as well as Parkinson's disease. And we oftentimes hear about Mirapex or Requip, and so that's the class that these drugs fall into. These are dopamine agonists. And we use these sometimes before levodopa, but again, we can use these in combination. If patients don't want to be taking a high dose of levodopa, this is certainly something that we can use to balance it out. Now, they're not as effective as levodopa, but certainly they come with different side effects and fewer of those motor fluctuations, right? The dyskinesias and the wearing off. You're going to have less of a problem with the dopamine agonists, so that's a benefit of these drugs. The ones that we see most commonly are going to be the first three on this screen, so pramipexole or Mirapex, ropinirole or Requip, and then rotigotine or Nupro, which I saw a table here for, and that's actually a transdermal patch. So you can place a patch on your skin, no pills to take. Bromocriptine, which is at the bottom of the page, is actually an older drug Patients still take it, certainly, but it was kind of one of the first ones that came out, and so it's not quite as popular as the others these days. Another one that's kind of an exciting one is apomorphine or apokine. Have you guys heard of that one? Anybody using that you want to admit to? Apokine, it's an injection? Yeah. Okay. So basically, apokine or apomorphine also falls under this dopamine agonist heading, although it works very differently in terms of how we take it. Okay. So most of these we'll take a couple of times a day, just the same way we would with levodopa, carbidopa. But apomorphine or apokine is actually for patients who experience freezing. So oftentimes later in the course of the disease, if you're getting stuck, it's an injection that can be given in the same way that we would give insulin. And it just gives a big push of dopamine, big push of the effect that we need, and helps to right the patient and helps to get them moving again. Okay, so this is something, again, that if you haven't seen it yet, great, but it's something that you might see at some point in the course of the disease, especially if you're experiencing what's called freezing. So a couple of unique side effects for dopamine agonists that I need to mention. If you've taken these drugs, you may be familiar with these. Sleep attacks tend to have a pretty bad, rap, but what happens is with the dopamine agonist, we can actually see an increase in tiredness, in sleepiness, and sometimes that happens really quickly. So we call it a sleep attack. So you just want to be careful until you know how the drug's going to affect you, that you're not doing things like driving or operating heavy machinery, so that you know how it's going to affect you and whether or not you're going to be experiencing these sleep attacks. A couple of other things. I mentioned that these drugs are less likely than levodopa to cause the motor fluctuations, so that's a positive. But one other negative that I should mention, or potential negative, I guess, is impulse control disorders. So these actually happen in about 15% of patients who take the dopamine agonists. And what this means is actually an increase in compulsive behaviors. So we can think about this in terms of gambling or sexual activity. So those are kind of the scary parts. But it can also present as things like an increase or a compulsion to garden or clean. So it can present in a couple of different ways. Certainly, we're scared of the ones that are going to be a little bit more, negative seeming, but it can present in a couple of different ways. And so you want to be sure that this isn't something that you're afraid to admit to a provider. That's something that I oftentimes see where there's a big gambling problem and a patient's just afraid to admit it because they don't link it to the drug that they're taking. And so this is something that we want to make sure that the lines of communication are open with your pharmacist, with your physician, so that if you're experiencing any of these impulse control problems where you're having compulsions, you're doing things that you're not used to doing or doing them at a higher rate, that you are talking about that, because there are options that we have that we can change drugs, try new things that can help to kind of put these side effects at bay. Another thing to keep in mind with the apomorphine in particular, so that's the injectable again, there can be severe nausea and vomiting with that, and so oftentimes you'll have to kind of pre-treat with something that's going to decrease your nausea and vomiting. But again, since it doesn't seem like a whole lot of people are taking that in the room, it may not apply yet. All right, so this is kind of the lecture part of the day. I know it's a lot of information to take in, but I'd rather you guys have all the information and be able to refer back to it as it applies to you than just not give it to you, right? So we've got 2 more classes to go through, and these are a little bit quicker. So decreasing acetylcholine, I mentioned that I'm going to talk about acetylcholine a little bit today as kind of a counterpart to dopamine. And so the way I see this is there's a dopamine acetylcholine seesaw in the brain. And in this picture, you can see that we've got less dopamine, and the acetylcholine is weighing us down. And so basically what happens with this, when we've got so little dopamine as we do in Parkinson's disease, that's when we get those motor symptoms. That's when we get the tremor. That's when we get the slowness of movement. That's when we get the rigidity. But what we want to happen is we want the dopamine and the acetylcholine to be about equal. And so what we have to do is actually work against the acetylcholine to get it back in balance with the dopamine. So the anticholinergic medications are the ones that are going to work against acetylcholine. And anticholinergic is a term that I'm going to use a lot because, to be frank, there's not really another way to say it. Yeah. So basically, these medications, these anticholinergics, oftentimes are used in younger patients, and they're often used specifically to target symptoms of tremor and also a side effect of drooling. And that's because of the side effects that they have. And these side effects certainly limit the use of these medications in patients who are older. Your definition of older may vary, but we certainly want to be looking out for things like dry mouth, dry eyes, blurred vision. Urinary retention and constipation are oftentimes problematic with these drugs, but more so what we're worried about also is confusion, right? So that can be a real problem, maybe something that we're already dealing with, and so we don't want to compound the problem by adding on an anticholinergic medication. These come in a couple of different forms. Most commonly, you'll see benztropine or cogentin or trihexyphenidyl or artane. And so these are medications that are on the market. They are useful. They do have a place in therapy, but they may or may not be something that you're familiar with or that you're ever given during the course of your Parkinson's disease. All right, the last one I'm going to talk about is kind of an interesting one. It's actually an antiviral. It was used to treat viruses, and then it was found to have an improvement in Parkinson's disease symptoms. So we always find drugs in the most random ways, and this is just one more example of that. So amantadine is another medication where we've got, we're not entirely sure how it works, but we know that it probably works on dopamine and acetylcholine in some way. But how it works is probably less important to you than where it works. And so oftentimes we'll see it used early in Parkinson's disease, but we'll also see it later on in patients who are having trouble with those dyskinesias, so some of those dancing movements or the contractures where they're stuck in awkward positions, so those motor symptoms, and we'll use those in later stages to help decrease those side effects. So we can use this oftentimes in combination with levodopa, carbidopa later in the disease. So amantadine actually comes in capsule form and also in an oral solution, so you can drink it, kind of a nice option. But it does have some unique side effects. So I said we think it works on acetylcholine, so again you end up with some of those anticholinergic side effects. I think of those as kind of the slowing down of the body, the dry mouth, the dry eyes, the confusion, the constipation, all of those drying effects. There's also the potential for ankle swelling, and also a blotchy, reddish, purple colored rash. So looks something like this. For those of you in the back, you probably can't see this, but certainly if you search for the rash with amantadine, you can find it online. It doesn't look too bad here. It just kind of looks like a little bit of blotchy skin, but it can get worse. It can look more severe and turn kind of more, just more obvious. But oftentimes this is not a problem. It's not a sign of a worse condition. It's not anything that we can treat with a medication. It's just something that we either have to learn to live with or that goes away on its own. But again, it's so important to be mentioning these things to your doctor if you're noticing them, because they can look to see if it's something else underlying the medication side effect. But most commonly when we see this in a patient who's on amantadine, it's going to be a result of the amantadine. So I said that we would talk a little bit about the common side effects of these medications. And so nausea and dizziness are two big ones, right? So you've already got Parkinson's disease. Dizziness is probably not the best side effect to add on with your medications, but we do it anyway. So these are the agents that we've got, and this is unfortunately what we have to deal with because the reduction in symptoms is so great, and the effect on Parkinson's is so impressive with these medications, and so oftentimes we're willing to just put up with these side effects, work around them, and get through it. So nausea and dizziness are unfortunately common with all of the Parkinson's disease medications. I can't necessarily recommend one to you that's not going to give you these side effects. But what I can do is give you some suggestions for how to work around them. So with nausea in particular, we can give medications with food. That can sometimes help. One thing that you do have to look out for, though, is particularly with levodopa, as we get further into the course of the disease, the foods that you eat may affect how effective that levodopa is and how long it works for. So that's something that, you know, if you're having trouble with the levodopa and you're eating it with food, or you're taking it with food and you notice that your motor symptoms aren't as controlled, that might be time to talk to your doctor about maybe making some dietary recommendations. Additional recommendations for dizziness, these aren't medication specific, but certainly what can happen with the dizziness is actually when you get up, it's kind of a dizziness that hits you, and it's from a drop in your blood pressure when you stand up. And so one of the things that we can do is just recommend slowly standing. So if you're moving from the lying down position to a sitting position, sitting on the edge of your bed before you stand up. for a few minutes can certainly help to decrease that dizziness. And just making sure that you're not doing anything too quickly when you're first getting up from a seated or a lying down position will help to decrease some of that dizziness. Another set of side effects that I wanted to mention, again, not pretty to talk about, but hallucinations and psychosis. And in the same way that we can see kind of differences in how severe or how troublesome the impulse control disorders can be, it's the same way with hallucinations and psychosis to a degree. So sometimes the hallucinations will be seeing a loved one or seeing an animal or just seeing something that's not necessarily unpleasant, but that's not there. But then there's also the potential for those hallucinations to be problematic. And so there might be some paranoia, there might be some psychiatric issues associated with it. And so these are things that are very real in the Parkinson's community and are very real with the medications that you're potentially going to be taking. But there are things that we can do to help manage these symptoms, whether it's changing the medications that you're on, adding different medications, considering alternatives. And we also have medications that we can use to help decrease some of these side effects if it gets to the point where it's really problematic and your doctor and you agree that you want to try something to help decrease the hallucinations or the psychosis. And so that would be what we call an antipsychotic. We do have a couple of options there. So at this point, I wanted to actually show a video from the Michael J. Fox show where he talks about wishing that his medication side effects were anything that Aquaman did. So unfortunately, we don't have any medications that will give you Aquaman-like effects, but we do have a lot of different opportunities that you can take to really minimize the side effects that you're experiencing. And so part of what I wanted to do today was really encourage you to be a partner in your healthcare and to talk to your pharmacist, talk to your physician about the things that you're experiencing. Because as scary as these medications can be, we know, by those of you that I'm looking around the room and you're sitting still, I know that these medications are working for you, right? And so we want to make sure that we're doing everything we can to keep you feeling good on those medications and feeling like you're in control of your health. So I have a couple of rules of medication use for Parkinson's disease that I want to talk about briefly. So I want you to remember that every person with Parkinson's is unique, and so is their medication regimen. So even though we have people who are using Apokine, and we've got people who are using dopamine agonists, and we've got some people who don't even know what I'm talking about when I say carbidopa, levodopa, there are a whole host of people who do know what I'm talking about. And so these medications will affect each of you differently. You're a very unique and special snowflake, and you're going to be treated as such, right? So don't be put off by the fact that you're on a regimen that's different from someone else. It's not necessarily going to be better for you to be on someone else's medications. As your Parkinson's disease changes over time, so will your medication regimen. I can't emphasize this enough. As things progress, you may go from a dopamine agonist to levodopa, carbidopa. We may add a dopamine agonist back on. I mean, it's so complicated. We've only got, 10 drugs that we can use, but somehow we make all of these regimens work out. And so your Parkinson's regimen will constantly be changing, and that's okay. That's normal. You want to report any medication changes that you experience to all of your healthcare providers. This is, again, very important, but oftentimes underutilized. So if you have a medication that changes, whether it's for your Parkinson's or for any other health condition that you're on, you want to make sure that your doctor, your pharmacist, your dentist, whoever is in control of your care is aware of those changes so that they can make sure that what they're prescribing, what they're recommending, are safe for you to use. Also, any side effects you notice, report them to a healthcare provider. Just because I mentioned them on the previous slides doesn't mean that they're not worth mentioning, right? If anything, you want to just be communicating with your doctor, communicating with your pharmacist that you're experiencing a side effect, and they can make sure that it's not a sign of something more serious. And they can also help you to manage those side effects if there's something that we can do for you. Also, even though I think it's a common misconception that because we're treating a symptom and if we are just taking the medication, well, if we don't take it, no big deal, I just will have symptoms. But we don't want to abruptly stop or change any medications that we're taking because sometimes we can have side effects from stopping medications quickly. So any changes that you want to make with your Parkinson's medications, talk to your doctor, talk to your pharmacist before you make those changes. Also, always, always, always ask questions if you have them. I teach in the School of Pharmacy. My students have questions all of the time. I expect my patients to have questions all of the time as well. So don't be afraid to ask questions. All right. So that was the big bulk of what Parkinson's medications are, what they do. Hopefully for some of you it filled in the gaps, and hopefully I didn't scare too many of you. We will talk just briefly about prescription medications to be avoided or used with caution in Parkinson's disease. And I'm just going to mention these briefly because we've actually got some handouts at the VCU School of Pharmacy table out in the lobby that you can take, and that will identify all of these interactions. So we'll start off with the hallucinations and psychosis. We'll go from, I guess, we'll start with the scary stuff first. So the hallucinations and psychosis, this can be a very scary thing to deal with, but we do have options. The challenge with addressing hallucinations and psychosis, whether or not it's related to medications, is that the medications that we use, the antipsychotics, have the potential to worsen movement symptoms. And so it's very important that, again, all of your care providers, whether it's your neurologist or someone else, knows what you're taking so that they will think to, potentially avoid these antipsychotics. We do have a couple of options that are relatively safe to use in Parkinson's patients, and I have those listed here. So you'll hear about Seroquel and Clozaril, that's quetiapine and clozapine. And so those tend to be our safer options when we're trying to address hallucinations and psychosis. For pain in general, you're pretty safe. Tylenol is always my go-to agent, but also any of the over-the-counter pain medicine may be appropriate for you depending on your age and other conditions that you might have. One of the things that I always, am concerned about with a strong pain medication, a narcotic, your OxyContin, your Percocet, is that you do have the potential to experience constipation, confusion, and psychosis, which I'm pretty sure with Parkinson's and with the medications, those are things that come along with the disease and with the medications as well. So we don't want to worsen those, but certainly if you're having a pain symptom, we don't want to undertreat your pain. So we can use these medications, but just keep in mind that these are very common side effects of opioids or strong pain medications, what we call narcotics. And so just use them cautiously, and certainly, start with low doses and try to work your way up rather than just, getting the most bang for your buck. One of the things I'll mention, I talked about the fact that the MAO-B inhibitors, remember one of those bodyguards of dopamine, the selegiline and noracillin, those drugs tend to have a lot of drug interactions. And in one case, we've got a couple of the strong pain medicines that can interact with those drugs. So if you are, again, experiencing pain and you're on one of these drugs, selegiline or noracillin, we may have to be a little bit more creative with what we are giving you. And sometimes it really just matters about dose, so that's something else to keep in mind. These aren't necessarily absolute, stay away from these drugs, but we will have to really consider what we want to give you and maybe how you've reacted to things in the past. So for nausea, this is one that hits pretty close to home for me. I actually had a grandfather who didn't have Parkinson's disease, but took the second drug on that list of medications to avoid, metoclopramide or Reglan, and he shook until the day he died, I'll tell you what. And it's a medication, the medications to avoid on that right-hand column are medications that we use to treat nausea and vomiting, but that can also cause, again, movement problems. They can cause symptoms that look like Parkinson's, and oftentimes patients will be started on these medications, and then their symptoms will be misinterpreted as Parkinson's disease, and they'll be treated for Parkinson's disease. So it's a little scary, right? But we just want to make sure that, if we're going into the hospital, that we're having someone communicate for us if we're unable to communicate for ourselves, that we've got Parkinson's disease and that these are potential medications we'd want to avoid. Luckily, we do, again, always have safe alternatives for the medications that we can't use. And so there are a whole host of medications you can see on the left-hand side that are potential to be used. I will make a mention, since I'm a pharmacist in the United States and don't normally talk outside of the country's meds, domperidone at the bottom of that list of preferred medications is actually only available in Canada. But having worked with a variety of neurologists over the years, I do know that it's a medication that's oftentimes recommended for patients who have severe nausea or vomiting. Anxiety and depression. This is another one where we've got to be creative if you're taking selegiline or rasagiline, because sometimes the medications can actually work in the same way or work to enhance the side effects of the antidepressants that we use. And in fact, selegiline has some antidepressant qualities. It's actually approved for use for depression. And so we just want to make sure that if you're taking selegiline or rasagiline, that you're being safe with the choices that we're making, and that, again, everyone involved is aware of the medication so that we're not getting into an unsafe territory with drug interactions. Amoxapine, the other medication to avoid, I'll tell you what, I rarely see it in practice, but it is floating around, and the reason that it's on that list is because it can worsen motor symptoms in Parkinson's disease. The preferred medications, this is just a list of very common antidepressants that we use, but there are certainly others that are safe to use. So if you're not using one of these on the list, but you're using something else, again, not necessarily wrong. I'm not here to tell you that your drug regimen is right or wrong. I'm just trying to give you an idea of some suggestions that might work and some things that you may see more commonly prescribed for patients with Parkinson's. My little take-home point, again, with this section is you really just want to be careful about any medications that you're adding onto your Parkinson's regimen, whether it's because of drug interactions with the medications you're already taking or because it has the potential to worsen your symptoms as they are with Parkinson's disease. And so we also want to be careful with anything that we're putting into our bodies. And so one of the things that I always tell my students and that I always tell my patients is, even though I'm a pharmacist, I don't want you to be taking more drugs. So always consider non-drug therapies. So if you can go and if you're getting benefit from counseling and you don't need an antidepressant, well, that's a great thing, right? You're not putting yourself at risk for side effects. You're not putting yourself at risk for drug interactions. But we realize that in some cases medication will be necessary. And so we just hope that you're taking into account what it is that you're taking and that you're sharing that information with your doctor and pharmacist so we're making smart choices for you. The last thing I'm going to talk about, as I mentioned, I'm very sensitive to the fact that the over-the-counter section is overwhelming. It's a scary place for me to be, and I'm trained in that area, right? So we'll talk a little bit about the cough and cold section. Again, rasagiline and selegiline are going to come up a couple of times, so just bear with me. So we'll talk about antihistamines, decongestants, cough suppressants, expectorants, and I'll actually define what those mean. So antihistamines are medications that we use to combat sneezing, runny nose, itching, watery eyes, all the stuff that I had 2 weeks ago. The preferred medications are going to be the ones that we use that are non-sedating, the ones that are not going to put you to sleep. So loratadine or Claritin tends to be kind of the easy one to go to, tends to be a safe option for patients, and it has no known interactions with medications for Parkinson's disease. There are others on the market that your pharmacist can help you find that will work in the same way as Claritin. The challenge that we run into are with these sedating ones, right? So these are the drugs that we think of like Benadryl or Dramamine that can just knock you out. And so the problem with these is that, again, they knock you out. And so if you're taking a medication that has anticholinergic side effects, so if you're taking one of the anticholinergics we talked about, or if you're taking amantadine, which, again, has anticholinergic side effects, that slowing down, that dry mouth, those dry eyes, the constipation, all of those side effects will be worsened by the sedating antihistamines. So the things we want to be looking out for are the Benadryl products and also anything with PM in the name. So Tylenol PM has Benadryl in it, okay? So those are the things that we want to be looking out for. And certainly, there may be a place in therapy for these, but again, you do want to check with your doctor to make sure that this is something that they're comfortable with you taking. I always think it's better to be safe than sorry. And so if you have the option to take a non-sedating antihistamine, I'd prefer that you did that. With decongestants, these are the ones that help to break up the mucus that makes your sinuses feel all stuffy and full. And there's a couple of different varieties of these, pseudoephedrine and phenylephrine. It's basically Sudafed or Sudafed PE. I don't know why we make these names so complicated. It also shows up in combination products that contain the word D, like Claritin D. So this is how we trick you, right? The problem with these medications is that you want to avoid their use with selegiline or rasagiline. Again, they can cause some side effects and some drug interactions that are not pleasant and that can be very risky for you, including an increase in blood pressure to an unsafe level. So we want to be cautious and really avoid the use with rasagiline or selegiline. And we also want to be careful when we're using them with anticholinergics. So we really don't want to worsen any of the symptoms or the side effects that you could be experiencing. So the drugs that we want to be looking out for here are the combination products that contain the letter D or Sudafed products. The other thing to keep in mind is that the phenylephrine piece of this, so the Sudafed PE, actually has the potential to increase tremor activity. So whether you're taking selegiline, rasagiline, an anticholinergic, or whatever else, we're probably going to want to be avoiding phenylephrine regardless. All right, the next one is cough suppressants. These help relieve coughing. They suppress cough, right? And so the way that we see these, the most commonly would be dextromethorphan, which is in Delsym, or DM-containing products, so like Robitussin DM. And again, these are drugs that we want to avoid with selegiline or rasagiline. I keep saying it, and I'm sorry to say it, but selegiline and rasagiline do have a lot of drug interactions, so you want to be sure that you're communicating with everyone involved so that we can find you safe options for over-the-counter use. The last one that I'll talk about is kind of the easy one. The expectorants, the ones that help bring up the mucus that is causing a cough in some cases. So Mucinex and Robitussin, the active ingredient is guaifenesin, and that's an example of an expectorant. There are no known drug interactions with medications for Parkinson's disease. Yay! So we do have options out there. And I think when you're navigating the over-the-counter section, the important thing to do is always to look at the back label, try to look at the products that are in it, and try to stick with products that don't have 18 ingredients. Right, trying to find options that maybe have 1 or 2 ingredients that we can make sense of and that we can really make sure that there's no interactions with your medications. Because I think even when I look at a laundry list of medications that are on an over-the-counter product, I mean, it's a lot to take in, and it's a lot to think about when you're taking a lot of other medications. So trying to stick with simpler products, things that are going to target a single symptom as opposed to a whole host of symptoms, can oftentimes help. And when in doubt, ask your pharmacist. October is National Pharmacist Month, and so I'm very excited to be here, especially during the month of October. But that's what we're there for. And so if you're, when you're trying to find a pharmacist, certainly try to find someone who's going to be able to give you the time that you need when you're looking for over-the-counter products and is willing to look at the interactions that might be existing with the other medications that you're taking. And just, feel free to ask. Ask your pharmacist, ask your neurologist, ask people who are involved in your care who can help you select products that are going to be best for you. Because I know that this is complicated information. I know this is a lot to take in. And I know that you're going to be walking around the over-the-counter aisle with my hand out trying to make sense of it all. And so if you're having trouble, just ask your pharmacist. That's what we're there for. So this is another one of those where I'm going to give a plug for the School of Pharmacy. We've got some great handouts that one of my students put together that gives you a guide to constipation, which unpleasant, but we've got to talk about it. So this is something that I just wanted to give you a little crash course in constipation. These are all products that you can find over the counter, so things that you can find in your local pharmacy. Dietary fiber, water, and fluids you can probably find in your own home. So this would be a matter of drinking more water, eating more fruits and vegetables. Even getting exercise can really be beneficial if you're able to walk around, go for a walk after dinner, or if you're more, if you're better able to move in the morning, go for a walk when you get up. Doing things like that will certainly help to move your bowels, keep things going in your body, and help to fight constipation. If drinking and eating right and getting exercise isn't enough, there are a great line of products from Metamucil. I don't get paid by them, but I do love their products. They've got some great wafers. They have tablets that you can take. They have powders you can mix into water and take extra fiber if you're not able to get it from your diet. Also, we've got products called Colace or Docusate, which will actually help to soften up your stool and help kind of hasten it getting out of your body. And then Miralax or polyethylene glycol, this is a powder that you mix with water and that will help to flush out your system. So we've got a couple of different products, and the handout that I said we've got at my table actually gives really nice descriptions of what all these are used for. If these aren't working for you and constipation is continuing to be a problem, definitely talk to your doctor about that. There are options that we can have prescribed for you that will help with constipation. I wanted to leave you with a couple of thoughts just in terms of general medication use. So regardless of what you're taking, regardless of what you're going to take in the future, these are some great tips, whether you're a caregiver or a patient, to always be thinking about. Before you leave the pharmacy counter, and most oftentimes before you leave the doctor's office, you'll have answers to these, but certainly make sure that you know why you're taking the medication you're prescribed, whether it's safe for you to use, and especially whether it's safe for you to use in combination with the other medications you're taking. How you should take the medication, so that can mean a couple of different things. How often do you take it? A lot of the medications we use for Parkinson's are going to be multiple times a day, so you want to know that. I mentioned that with in some cases, food can interfere with the effect of the medications, and so you certainly want to be asking questions about that. Can you take it with a meal? Do you have to take it on an empty stomach? How long should you take it? So if it's something like an antibiotic, are you going to be on it for a week? Or is it something like levodopa, carbidopa that might be a couple of years? And also, what are the side effects? You want to know what to expect, what's normal, what's not normal, and when do you need to call your doctor. And lastly, keeping an up-to-date medication list. This is my last plug for our table, but we've got medication lists that you can take and fill in with all of your medication information so that it's easy for you to go to the doctor, go to the pharmacist, show them your medication list. You don't even have to say anything. But you want to make sure that the products that are on that list include your prescription medications, your over-the-counter medications, and any vitamins, herbals, or supplements you're using. And I mean multivitamins, if you're using ginger, if you're drinking green tea even, we want to know about all of that stuff. And don't forget about things like creams, patches, inhalers. Just because it's not a pill doesn't mean it's not a medication, okay? So certainly keeping an up-to-date medication list is one way that you can take a really active role in your health and that you can make sure that everyone in your care is involved so that we're able to give you the most bang for your buck from these medications. Thank you so much for having me, and I'm happy to answer any questions at my table. Thanks. Oh, thanks.
Thank you, Emily. That was a lot of information, and we are so happy that you have a thorough handout. So we can get pretty stiff sitting all day, and so we wanted to include an exercise break to help combat some of our fanny fatigue. And to do this, we have Annette Hyde with us. She is a yoga instructor with over 13 years of experience, and she specializes in yoga for older adults and for those that have cancer. She's also going to be doing one of the breakout sessions later this afternoon if you would like to participate in that. Please welcome Annette.
There's only so much sitting you can do, right? For those of you who are unable to stand up, please, you can do what we're doing in your chair. For those of you who can stand up, please stand up. That in and of itself probably feels really good right now. If you need to be close to your chair, please feel free to hang on to a chair. If some of the movements that I do don't really work with you, feel as if you're doing the movement anyway. So we're going to start from the bottom of the body and work our way up. So we're going to start with your right foot, whether you're seated in a chair or you're standing up. Hold onto a table or a chair and just start to make ankle rolls with that right ankle. Just about 10 slow to the right. That's a problem with the podium up here. Usually in yoga we do this with the shoes and socks off, but that's a little difficult right now. And then once you've done 10 slow ankle rolls to the right, just do 10 to the left. Go with whatever your range of motion is in your ankle. And then once you've done about 10 or so, or as many as you feel like doing, place your right foot down, you got to go the other side, right? So take your left foot, lift it up, and do 10 ankle rolls to your left, slow. Just notice the feeling of your ankle, what it feels like right now. Probably better than it did earlier. And then reverse it. Do about 10 to your right. Since it's now colder weather, we tend to forget about our feet. I'm a flip-flop person during the summer. I don't like wearing shoes. So I tend to forget about my feet when they're covered up. And just place your left foot down for just a moment. Just notice your feet. Just notice they feel a little bit better. And if you're sitting in a chair, what I would like for you to do, if it's possible for you, is to pick up your right foot. And you're going to straighten your leg and bend your knee. If you are standing up, have your feet about hip width apart. And just start to bend the knees just a little bit, just a little bit. And then stand up, just little knee bends. And now if you've got bigger range of motion in those knees, you can bend them a little bit more. However, I want you to use your gluteus maximus back here. Take those hips back and up. You want to be sure your knees don't go past your toes. My husband has the world's worst squats because he doesn't use his glutes. He uses his hamstrings back here. So it's just a little knee bend, it's just to warm up the knees. And then you can shake your legs out. Come on, stand up, shake your legs out. Now, either sitting in a chair or standing up, imagine you've got this big hula hoop around your hips and you're going to circle those hips to your right. I taught kids fitness for about 15 years and used hula hoops. And everybody laughed at Miss Annette because Miss Annette was the only person who couldn't keep the hula hoop up. I had many 5-year-olds who could out hula hoop me. And then coming back to center, and then just roll those hips to the left. Just make this hip roll as big as you want to, whatever the range of motion is in your hips. Just get those hips moving a little bit. And then come back to center. And again, let's read this thing about your posture for just a moment. If you're standing up, your feet are underneath your hips, knees are a little bit bent. Kind of tone and lift through your belly and broaden through your collarbones. Stand as straight as you can. And if you're sitting in a chair, again, sit up as tall as you possibly can into the chair. Take a deep breath in here, and as you exhale, just slide your right hand down your right side. And as you inhale, come back up to center. And as you exhale again, and then come back up, and slide that right hand down the right side again. And come up. Think about, as you're sliding the hand down, the bottom of your ribs and the top of your pelvis coming toward each other. And coming back up, and down, and up. And everybody's still breathing, yes? I tell all my yoga students, everything what we do in class can be changed or is optional. Breathing is mandatory. Let's do one more on this side. And I'm going to come over here so I can do the left side. So y'all can see me over here. So slide the left hand down the left side and come back up to center. What you want to try to do is when you come back to center, is keep the shoulders centered over your hips instead of going over to your right side again. This allows you to work your core just a little bit more. And just breathing and stretching that right side out. Coming back to center. All right, and then from here, either you're still sitting in the chair or you're standing up. Imagine you've just got empty closed sleeves on and you're just doing a little twist side to side, just shaking your empty closed sleeves. If you're sitting in a chair, just do what you can right here. Just a little twist side to side. Everybody has to twist. And you can make that twist a little bit bigger or not. And if it needs to be smaller, that's fine. Just go wherever you are right now in this moment. My mother had Parkinson's disease for 11 years before she died in 2012. And every day was unique. There were days that she could move really well, and there were some days that it was very difficult to move. So wherever you are in this moment, that's where you need to honor yourself. All right, coming back to center. If you would like to sit down now, please sit down. Go ahead and sit down. Could I get a chair? So everybody sit down. Everybody feel a little bit better? So sitting in the chair. Now, sitting in the chair does not mean you get to slump back. Try to sit up in the chair as tall as you can. You can either have your hands in the chair or you can have your hands in your lap. And as you inhale, I want you to imagine there's a string attached to your chest and it's lifting that string up toward the ceiling. The head doesn't necessarily have to come with it. And then as you exhale, bring your shoulders back over your hips. Not forward, just over your hips. Inhale again. Imagine that string is lifting your chest toward the ceiling. And if you're lifting your head, try not to do this. And then exhale, bring your shoulders over your hips. Inhale again, lifting the chest. And then exhaling, bringing the shoulders over the hips again. Inhale, lift the chest. And exhale. Inhale, lift the chest. And exhale. Let's do one more time. Inhale, lift the chest. And exhale. Take your arms out. Please be sure you're not smacking somebody when you do this. Now, ladies. Take a deep breath in here, and as you exhale, give yourself a big hug. Hopefully you didn't spill anything. Inhale, open up. And exhale, cross your arms the other way. Give yourself a hug. Stretch out through your upper back. Inhale again, open those arms out. And exhale. Inhale, open those arms again. And exhale. Excellent. All right. Take your hands to your legs and just roll your shoulders up, back, and down. Both shoulders up, back, and down. I like to do up, back, and down. Now take your hands up. Everybody take your hands up. Make fists with your hands, but please do not dig your fingernails into your fists. And then fling those fingers open, just like you got water on your hands. Make a fist. Fling. Fist. Fling those hands. Imagine you're in a pool with nieces, nephews, grandchildren, or whatever, and they're trying to splash you, and you're getting them back. So make fist and fling. One time, fist and fling, and then take your hands into your lap. I'm going to teach you a yoga pose called Simanasana, which is lion face. The way you do this is you open your mouth really wide, and you stick your tongue out, and you look up, and you... So everybody, open your mouth really wide, stick your tongue out, try to touch your tongue to your chin, open your eyes, look up, and... Do it a couple more times. Take a deep breath in. And then one more time, inhale. And then close your eyes for just a moment, sit as tall as you can, and just enjoy your breath. You can enjoy that too. But just enjoy the movement of the breath in and out of the body. Just notice how you feel in this moment. Take a deep breath in here, and as you exhale, just say, Inhale again deeply. Exhale. Inhale one more time. Open your eyes. Bring your hands to your heart. Bow your head to your own heart. Namaste. I hope to see all of you at 2:35 for my exercise session. Breathe, move, and relax. Thank you so much.